A third strategy to address the burden of communicable diseases on the health of a community is an identification of cost-effective treatments. Cost-effectiveness is a concept that combines issues of benefits and harms with issues of financial cost. It starts by considering the benefits and harms of an intervention to determine its net effectiveness or net benefits. Net effectiveness implies that the benefits are substantially greater than the harms, even after the value or utility, as well as the timing of the harms and benefits, are taken into account. Only after establishing net effectiveness do we take into account the financial costs. Cost effectiveness compares a new intervention to the current or standard intervention. It usually asks, is the additional net effectiveness of an intervention worth the additional cost? At times, it may also require us to ask, is a small loss of net effectiveness worth the considerable savings in cost? The figure shown here is a tool for categorizing interventions in order to analyze their cost effectiveness. The application of cost-effectiveness criteria to common clinical intervention is considered a population health intervention aimed at getting maximum value for the dollar spent. Preventative interventions undergo cost-effectiveness analysis. Many interventions, ranging from mammograms to most childhood vaccinations to cigarette cessation programs, get high or at least passing grades on cost-effectiveness. However, many widely used treatment interventions do not or would not meet the current standards for cost effectiveness. The result of cost effectiveness analysis have already had an impact on a number of common clinical procedures. For instance, cost-effective treatments include the use of minimally invasive orthopedic surgeries such as knee surgery, the reduced length of intensive care and hospitalization for coronary artery disease, and the use of home health care for intravenous administration of antibiotics and other medications. These efforts to increase the cost-effectiveness of routine healthcare procedures are becoming key to maximizing the benefits obtained from the vast amount of money spent on healthcare in the United States. Improving the ability to predict the outcome of disease and intervention can help us know when, how, and whether to intervene. Another tool used in the identification of cost-effective treatments is a QALY, or Quality Adjusted Life Year. This is a measure of disease burden including both the quality and the quantity of life lived. It is used in assessing the value for money of a medical intervention.
When we are making decisions about how to allocate healthcare resources across many different interventions and for many different patient groups, it is extremely difficult to compare benefits if we're using lots of different PROMs, all for different clinical areas. To compare evaluations, we need a single measure of benefit. One solution to this is the Quality Adjusted Life Year, or QALY. A QALY combines length of life and quality of life into a single index measure. When we are looking at evaluating the benefit of treatments, some treatments may have an impact on length of life, some on quality of life, and some on both together. The QALY takes both of these into account. QALYs give us a common unit of benefit which we can use in an economic evaluation to compare interventions both within and between clinical areas. To calculate QALYs, we multiply the length of life by the quality of life. Length of life is typically measured in years, and quality of life is measured on a scale of 0 to 1, where 1 is equivalent to perfect health and 0 is equivalent to dead. For example, 6 years lived in perfect health, valued as 1, would give 6 times 1, which equals 6 QALYs. 10 years lived at a quality of life valued as 0.5 would give 10 times 0.5, which equals 5 QALYs. To compare treatments, we can calculate the number of QALYs for each and work out the difference between them to see if there is a QALY gain. Let's look at a few examples. Imagine we are comparing a new treatment for kidney failure with an existing treatment. The new treatment would extend a person's life by 4 years, from 2 years to 6 years, and increase quality of life from 0.75 to 0.8. With the existing treatment, a patient can expect to live for 2 years at a quality of life valued as 0.75. 2 times 0.75 equals 1.5. Therefore, the existing treatment has a total of 1.5 QALYs. With the new treatment, the patient can expect to live for 6 years at a quality of life valued at 0.8. 6 times 0.8 equals 4.8. Therefore, the new treatment has a total of 4.8 QALYs. 4.8 minus 1.5 equals 3.3. Therefore, the QALY gain is 3.3 QALYs.
So with a QALY, what we're doing is we're looking at interventions and looking at each year of life added because of the intervention. And each year of perfect health is assigned the value of 1, down to a 0 for death. If the extra years would not be lived in full health, then the extra life years are given a value between 0 and 1. Once we've calculated the QALYs for an individual intervention or treatment, how do we place a dollar amount on that? Well, the value is placed on QALY based on what a society is willing to pay, and generally that's based off the gross domestic product. In the United States, it's about $50,000 per QALY. So let's calculate the QALYs times the $50,000 from our example. It was calculated that the new treatment would provide 3.3 additional quality adjusted life years times $50,000 equals $165,000. In our example, the 3.3 years was actually 4 years of extended life. So if the treatment over those 4 years exceeded $165,000, one might assess that it is not a cost-effective treatment. This is how QALYs are used in the identification of cost-effective treatments.